Hit me.
Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends. Thank you for listening to the Senior Rehab Podcast. Today, we have on the show another repeat offender from episode 29, Kathy Shirley. The title of that episode was Dealing Hope to Patients, Students, and Geriatric PTs. Kathy Shirley is an assistant clinical professor at Texas Women's University. She's an awesome woman. She's very active in the Senior Rehab Project Facebook group, very wise, and I appreciate her perspective on physical therapy, but then how can we impact our society on a much bigger level, which we do have the capacity to do. So I decided to have her on to talk about some of these bigger topics of how physical therapists can kind of break out of our little box of our little clinic or hospital or whatever to impact society at large. So Kathleen Shirley, welcome to the Senior Rehab Podcast. I thank you for your time at this very early morning.
Oh, it's great to be on again, Dustin. My pleasure. Yeah,
it's been a while. I think that episode, your first episode released at the end of May of 2016. So what's new? What's new since we had that conversation in terms of your job or your career or interests?
Well, one of the big things is I did complete my very first year in the academic world. So I have 1 year, 1 year under my belt. And it's been a great transition for me, really kept me fresh and continuing to be asking questions and looking from the perspective of students and other faculty members. So I've been very pleased to have that opportunity. It is hard work.
Yeah. What's the hardest thing about it? I guess the biggest surprise that is the most challenging?
I think it's just the amount of preparation. I'm sure all faculty members would say the same thing. You know, there is a definite desire by all of us to really promote the best evidence, to be very careful with our words. You know, we have young minds in front of us. Sometimes it's a little daunting. Did they really hear what I said? That's probably the biggest challenge, is making sure. And it comes back to communication. So very similar to how our challenge with patients is communication. Our challenge in teaching is communication. Are we really getting across what we think we are? And that requires that, you're asking those questions, you're testing to see, did I get across the right perspective? Is this what I was hoping to share? And then what are you getting back from students, or if it's patients, how do you have to proceed? So it's not that different from patient care in that respect. It's just that, I've got 54 people sitting in front of me at one time, not one.
Yeah, I want to encourage you a little bit. Just from my little experience, I am very knuckleheaded, and there are so many things in PT school, very profound things that some of my professors said to me that at the time I did not grasp or really care about. And I mean, even, 5 years out of school, there are some things that it just hits me like, oh, remember when Dr. Harrison said this about older adults, or Dr. English said this about, working with people with ALS, all these different things that just at the time didn't mean a lot to me. But now it's like, oh my gosh, that was amazing. Like, thank you. So just to encourage you that down the road, I'm sure there's going to be lots of light bulb moments for your students.
Yeah, I'm sure. And, and I still have those light bulb moments. I mean, and I've been out for a long time, and it'll be like, that's what that was all about. So yeah, it never really ends, but it's been fun, and I'm having a really good time, and it's, challenge is good for us. It's good for our brain. So I'm keeping my brain working.
Yeah. So in our last conversation that we had, we talked about trying to change perceptions of geriatrics, especially in students. Over the past year, what has been useful for you? Any tactics, tips, resources that you feel have really struck a chord with just kind of that younger population, the DPT students?
Well, I think what really works is to challenge their perspective. So, like anytime I am talking, I'm like putting up a photo or a link to some sort of YouTube video or talking about a particular patient case that, you know, the normal, maybe the average student has not been exposed to the potential for change, the positive change in our older adults. So they keep on seeing it, and I'm repeating it over and over. And it's fun because, you know, like my first year students have heard me in, you know, certain capacity of the courses. And then by the time I have them in second year, all I have to do is sort of put a slide up on the PowerPoint and say, so, you know, what do you think if I look at that slide, what's going to be my biggest concern? I don't have to tell them anymore, you know, so that they're already looking for it. And more are they sending me things and, you know, this is what you were talking about. And, you know, I can see that. So I can definitely see the change. And I think part of it is that we just have so much access to information outside of the medical world. So the medical world, I think, is changing a little slower, but because there's so much information outside, it's being challenged. So we're getting there.
Awesome. One viral YouTube video at a time. We're changing perceptions.
Yeah. That's right. That's right. Because, you know, if you look at somebody and you see, you know, somebody who's 85 and they have the muscle definition of what you thought somebody at 20 should have, well, it's going to change your perspective of what's possible. You know, I actually had a conversation with a faculty member, and she was talking about some video that she saw, and she goes, yeah, you know, I think we have to change the way we're looking at this. So I was like, and that's wonderful, you know, because I've been in front of presentations, you know, research presentations, and the way they qualified the older adult, the healthy older adult, was that they could walk one flight of stairs. I'm like, oh, please. Oh, wow. You know, if that's a qualification for that group, well, then of course the data is not going to be showing us. So yeah, we are getting there.
Yeah. That makes me think of Becca Georgery. She's a PT out of University of South Dakota, I believe, that works a lot with the senior athletes, and just the I guess the relative norms that she's seeing in terms of their performance is just continually, you know, increasing and improving. So that'll be cool to see, you know, how our norms for older adults change over the upcoming decades. Hopefully for the better. So, but I wanted to, I mean, you mentioned this in the Facebook group, after episode 35. So with Matt Miller, he's a PhD student, and we talked about changing behaviors and changing lives. And you brought up the topic of motivational interviewing. And this is something that I've heard thrown around a bunch, just, I guess, probably over the past year on social media. And it sounds amazing and sounds very useful. But I have very limited knowledge or experience in motivational interviewing. So tell me kind of the quick and dirty on this concept of motivational interviewing.
Okay. So, well, MI is considered a collaborative conversational style of counseling. And it's one that helps to strengthen the person's motivation to change. So, and it originally was researched and brought out in the addiction role. So in 1983, Milner was a clinical psychologist who wanted to change the way the strategy for counseling with addiction. And so he started working on this. And then he had another person, Rolnick, who really brought it into healthcare. So since 1983, there's been significant research being done on this, and really significant randomized controlled trials, meta-analysis done in the last 10 years. So this is very strongly supported by research that we should be using. I find it really interesting that I was really only aware of it within the last 5 years, right? And it's been well researched for much longer than that. So as much as we talk about research and evidence base, this gives us another idea of how long it takes to move into clinical practice or even into academics. You know, and so this is something that I really wanted to talk about because it is so evidence-based, and we should all know about it. It shouldn't be like some little cursory thing floating around. We should know what is MI and how can we get better at it? How can we learn to use it? And it's starting, you know, I sent you a couple articles. Beth Black did a really nice case report that was in the Journal of Physical Therapy Education recently. and they're integrating it within the classroom. So, and part of my taking the health coaching certification this past summer was to get better at this so I could bring it into the academic environment. But it's just a way of talking to your patient. So what we tend to do when we're working with patients is sort of tell them what to do. We're very much into we have to fix it. And that's like part of that comes from our training. We are experts. We have a certain amount of knowledge. So I'm just going to tell you, this is what you have to do. And research tells us that doesn't work.
Really?
So this is a different way of getting that information across to the patient by helping them sort of bring out the idea for change. And then they want the knowledge and they're asking for the knowledge, and now it's more a collaborative effort of, okay, so I see that you're really interested in doing this. This is part of your goals. Well, would you like me to give you a couple ideas of how we could do it? A really different way, instead of, immediately the patient walks in and, well, Mr. So-and-so, I see your strength is really very limited and we're having these movement problems. And so we're going to start with this and we're going to move to this. And this is how this is going. And, and the patient has sort of lost, they don't really have control over that. We've taken away their autonomy. And we have to give them that power. So they need to have that power to change.
That's a good point, and something I struggle with terribly.
We all struggle with that. So I don't think that, even I struggle with that. The one nice thing about motivational interviewing is it gives you these strategies to listen for when the patient is ready for change. And so like some of the terms they talk about is change talk. So like when you hear that, when a patient is saying that, oh, I can see how I have to get stronger in order to be able to do this, whatever their goal is. And so that's your inroad for, okay, so now they have acknowledged it. They've actually said it out loud. So now I can go ahead and start. Okay, well then how about we try this? That's always been something like in my early days of work that I really struggled with, and I think it comes with time that you see, well, it doesn't work to just say step 1, 2, 3, and 4. I have to get the patient engaged. I have to get them to say, okay, well, this would work for me. I could do this. So we have to be a little flexible sometimes. We are the experts, and I can really see how the students struggle with that concept, but but the evidence says we have to do this kind of therapeutic exercise, or this is the best. And I'm like, well, if your patient doesn't want to get into the water, it doesn't matter. So you have to sort of look at what are their values, what are their goals, which I know you hear all the time on your podcast. Everybody talks about that. So it's a common theme, and it's just understanding like, well, how do you hear those values and how do you really get their goals out of them?
Yeah. And when I think from the students' perspectives, that was for me, it's one of the toughest lessons I learned the hard way. I mean, it literally took me 4 or 5 years to realize this person doesn't want to do what I want them to do. I am not using my time wisely by continually trying to beat it in their head that they need to do X, Y, and Z when they haven't even bought in.
Right.
So when you found out about this and your eyes were open about 5 years ago, what was one of the toughest habits for you to break in interacting with patients after you've been enlightened by MI?
It's still, so MI uses the term the writing reflex, which is basically our need to tell people what to do. And so that's still the hardest thing, like I'm much better than I was, but what I still have to work on is that I need to stop sometimes. Like the patient's just not ready to hear anything more at that session. And we're really lucky that we usually see people several times over time. So we have to get away with it. We need to accomplish all the patient education and all of the information in like this one session, because it just doesn't work. So it's like spinning your wheels, and it's not going to be very productive. Just like how you said, it's just isn't productive. So you might as well not do that. The next session, you can see what works within that one session. You give them some idea. So like maybe you were able to get, so I had a patient recently that she's really trying to increase her activity again. And we had to come up with, well, what strategies might work at home, what's reasonable. And then after she starts talking through, well, you know what, I think I could get back and see if I could go to the Y. I'll see what kind of community, because I'm always asking them to find community support. And that I give that as homework. And I ask, is that reasonable that you go ahead and research what things are in your area? You know, if they have access to the internet or if they have somebody that can drive them, because I want them to see the facility besides just, go on the internet. It has to be a match. And we talk about that. You need to be comfortable there. Did you feel that when you walked in, you were greeted, that you were part of that? We talk about, the relationship within the community after they leave me. And so she went and she did that. And then she comes back and she goes, well, all right, so I found the Silver Sneakers program at this YMCA, and I believe I can go ahead and do that. And then there's a way of asking them, just how confident do you feel in doing that? And it's sort of like the pain scale, so how confident do you feel that you could get to the Y twice a week and on a 0 to 10, and then they'll maybe say, well, I can do that. That's an 8. And then if they say, well, okay, I'm like, okay, well, what makes you so confident that you can do that? So they can hear themselves out loud talk through how they're going to be able to successfully do that. And then it could be the other way. Like I've asked somebody to maybe go to a certain facility and they come back and they say, no, I just don't see that working. And I'll be like, well, okay, on a scale of 0 to 10, what is that confidence? How low is that? And they'll say like a 2. And I'll say, okay, well, then what are the barriers? Like what's keeping that from being successful? And then as they talk through that, I can see, okay, so this now becomes a big issue for them, so that I know the next thing that I'm going to suggest is not going to involve that issue.
Okay.
So you're just trying to figure out like, okay, so what on the top level of support do they feel they have? And now we need to expand more in that. And then if they've got something down on the 2 out of 10 confidence level, okay, can I build and change that, or do I have to totally switch directions? There's no reason to go. Like the Y is not going to work, or the senior center is not going to work. Because, some people say, I don't like to go into any kind of group. Well, then stop. If that's just their personality, we got to find something different, and at least in the beginning. Maybe we can change it later. But in the beginning, if I keep pushing that, then MI talks about discord. I've created like this little battle going on.
Yes. I'm all too familiar with that battle.
Right. So if we create that battle, we need to recognize the battle is ensued and nothing productive will occur at this point forward. So it is up to us to make the change, not the patient. And I think this is many times where we sort of go, well, the patient's non-compliant. Yeah. The patient's not following directions. And in reality, in the MI approach, the reality is that the non-compliance is because of the way the conversation is gone. It's your facilitation that needs to change. And then we move forward. So there's, it puts a lot on us. And sometimes we don't like that. That doesn't mean that MI says we help everybody, or just because you do this, you can help every single person. But it is so much more successful. And I can just tell you from experience that in the last 5 years of really starting to implement this, my ability to get people to continue to change, to facilitate change, to have an awareness of this would be very helpful is much improved. Yeah. Can I continue to get better at this? Absolutely. So I'm like a newbie in MI. So it's but this is something that I really do challenge everyone, especially in geriatrics, to try to improve a level of understanding and really look at, there's some great YouTube videos that you can easily access. You can go online and just Google MI. There's different certification programs, but I would definitely recommend that people try to move into this form of conversation with their patients.
Yeah, I see it as very valuable for many reasons, just to promote change and healthy behaviors, but even outcomes. Just the research that's been coming out on the impact of therapeutic alliance on episodes of care is just amazing. I know, Jerry Durham, Jeff Moore, David Reed, they talk about this stuff all the time, that, it has a tangible impact in our outcomes. And that just blows my mind away. And I really, I have seen that in home health, when, I've interacted with people like you and Matt Miller that have opened my eyes to how much I interrupt patients, how much I try and force things on them, how little I listen to them. and that's helped tremendously. But I have the luxury of spending, 2 to 4 hours a week in someone's home. It's very easy for me to connect with patients. What do you say to the rushed outpatient clinician that's seeing 4 patients an hour, or the acute care clinician that is only seeing someone for a couple of days? What things would you tell them to really focus on to have as much impact as possible in that limited period of time that they have to interact with the patients?
Yeah, and that's a great question, and that's probably one of the big pushbacks from clinicians, because their perspective is that this takes a lot of time. Mm-hmm. And actually, the research in healthcare has been based off of brief interventions. So MI moved into nursing and physician roles first, and they have busy outpatients, right? A physician, what do? Spend 5, maybe 10 minutes with you. And then the nurses, maybe they can spend a little more in an outpatient. A lot of this was with the more chronic types of problems like diabetes, congestive heart failure. That's where the real big push basic activity came, but in like the outpatient kind of medical setting. So they're using this very briefly. And it was really interesting. Like when I moved to Texas, I had to go ahead and have new physicians, start that all up again. So this was 4 years ago. And the first, my physician that I went to, she's using MI. I mean, I was like, oh, I know what you're doing with me.
Trying to pull a fast one, huh?
So, and obviously her encounter with me is 5 or 10 minutes. It's not this long thing. So it is set in the healthcare. It's being researched on brief interventions. So yes, in the busy outpatient facility, I mean, I'm also lucky. I do either home care or I do one-on-one for about 45 minutes to an hour in the outpatient setting. So it's easier for me. But for somebody rushed, you can still do the same thing. And the first idea is really to be able to recognize what is it that the patient is most worried about. And lots of times I'll ask them that, is there something that's really worrying you today that we should address first? So right off the board, they've been given the opportunity. It's an open-ended question. I want to listen to you. I want to hear what's going on. I think that one of the biggest things, if we have to work with somebody quickly, that we need to be aware of and address first is fear. So in most people, the worry has some fear-based. If it's an older adult, maybe, well, if I get up and move around more, I'm afraid I'm going to fall. So it's not going to help me if I'm really getting stronger, because then I'll fall and I'll break my hip. So we have to address, I need you to move more, but I intend that this will be safe, and that we will not be having a situation where, because you're just moving around, you have, you're going to be falling. But you have to validate that person has that fear. And then you can move into, how are you going to change that perspective of that fear? How do you support that fear? And what is the plan from there? And then again, the other big thing that MI talks about a lot, and I tell you, this is the first thing that I had pushed back on, was asking permission to give information. I was like, what? I know what they're supposed to do. I just need to give them this information. I don't have that much time. Even when I was like 45 minutes with a patient, I said, that's sort of silly. But let me tell you, that really works. Yeah. So you're just saying, they've come up with some sort of fear or some sort of worry, and I'll be like, oh, you validate whatever that is. And then, validation would be in repeating, okay, well, I hear that what you're telling me is that you're really worried about re-injuring this knee if you're doing this amount of exercise on a daily basis. And I'll say, okay, well, I have a couple options for you. Would you like me to start? And then they'll be like, okay. And then you give them a couple different ways. Well, we have this, or we can do this. And now I've given them a choice. Yeah. So now they have some power. So trying to understand that most people come to us with fear, and most people we've taken all their autonomy, all their self-efficacy away, and we have to figure out how to give it back.
That's awesome. And that is so applicable to the people that listen to this podcast, because so many of us are working on that back end of healthcare, where these people have been through every setting, had so many interactions, most of them probably terrible with the healthcare system, to where, like you said, that autonomy and dignity is just stripped from them. And then you, as a physical therapist, can give them a glimpse of that just in such a short interaction by asking that simple question.
Right.
That is good stuff.
Yeah, and one of the big pushes in general, that if you really follow like population health and how we're trying to change the chronic disease situation that's occurred in the United States, in the world, because like 85% of the cost is going towards behavioral type problems that have contributed to chronic disease and to premature death. I mean, that's like a phenomenal statistic.
Yeah.
So because this cost has like met crisis level, now everybody's pulling out the stops about, oh, no, now we need the patient engaged. Oh, and then you'll hear the term activation. Now we need to activate the patient. We need to give them the ability to, I mean, it's really the terms I find quite interesting, but that's a terminology that's out there. So now it's turning around. We have this big 180 degree that, oh no, you need to take control over your own life. When, for the last 30 years, at least the 35 years that I've been practicing, we weren't giving them any control. We are just telling them what to do.
Yeah.
And now we have the crisis of, boy, that didn't work. Yeah. So how can we change it? Yeah. And the change is to give people power back and for them to not be passive. We don't want a passive patient. We want to have that interaction. We want to have that collaboration, that ability that we are truly just facilitating change. So I come from a neuro background. We talk about facilitation a lot. I'm facilitating the person to move in a different way. I'm not making them move that way.
Yeah.
Uh-huh.
Yeah. And that's kind of the essence of our field, isn't it? In terms of just physical therapy, that we are teaming up with our patients to facilitate healing or change in their lives.
Right.
But often that can be forgotten in practice. So tell us about this certification that you did over the summer. So it's the Health Sciences Institute, and they have a chronic care professional certification. How was it?
Yeah, well, it was excellent. So I chose that because it was something that I do not teach in the summer. I had the time frame to do it, and it's an online program, so it's very convenient. There are other ways to do this, but this met my needs, and it was well done. So just looking at all the concepts of population health, what we're trying to do with chronic disease, which basically when you're working in geriatric physical therapy, you are dealing with chronic disease. So, it met my needs perfectly, and then it moved into motivational interviewing and how you can use that. So I got another level of understanding with motivational interviewing, which was a primary goal to take that. So, ultimately, I think all of us have to try to change our perspective of when we have that individual sitting in front of us. The conversation has to go to health. General health, not just maybe the situation that we're dealing with, because if we improve their overall general health, we improve the situation that brought us into their home or brought them to the clinic. It shouldn't be such a disconnect, sort of like, well, I'm the physical therapist and I really just deal with movement and whatever's going on within the body systems and that door to, well, how your nutrition is supporting our healing, how your general activity, how your mental health supports healing. I don't really do any of that. Sorry.
Yeah. I'll refer you to the appropriate professional.
And that doesn't mean that at the time there isn't an appropriate professional that you should refer, but the conversation can start with us that this is important, that this is part of the whole picture. The APTA, we're talking about our vision, and the first phrase is transforming society. Okay, well, we can't transform society with just this bullet point, one little bullet point. It's got to be a global view of how we address health. And our primary role is to improve the ability to move in a functional way, to regain the joy of whatever you lost in life that was around movement. That I think is our pretty much our big focus. And we certainly expand a little bit out of there, but it is getting people to move no matter what age. If you're in the neonatal intensive care, if you're working with somebody who's 105, we get into the room to get the person to move. So, but movement requires everything else. And there's been sort of a disconnect in us not necessarily drawing that into the conversation. Yeah. And
that's a good point. So after you went through this course, did you have any like light bulb ideas like, oh man, if our profession could just do this, or if, we could start this program or just whatever, creative ideas. Did you have any of those after you went through this course?
Well, I think my number one light bulb was how important it would be to bring into the entry level program. So instead of somebody hearing about it after they've been out of school for 30 years or for 5 years or for 10 years, they heard about it within school and they have the basis to then start becoming, I certainly hope to move towards mastery with this level of conversation with my patients. So the faster we try to expose our students to that, the more potential for mastery. And that was really the light bulb that came on. I personally would love to see myself in more of a health coach role, like maybe after I leave academics, that I would truly be doing one-on-one health coaching in a private pay situation. I mean, I don't know. There's a lot of ways this can go. And we see all sorts of there's all these wellness people, the personal trainers are doing wellness. We have everybody doing some level of coaching. I was like, this would be perfect for as far as a physical therapist with our background and our understanding in chronic disease. So my focus would be more in really helping the individual with chronic disease know that, hey, there's something you can still do about this.
Yeah.
And it's not just writing yourself off.
Yeah, that's such a good point. I want to transition into listener questions. Joe Daniels, he's a physical therapy student currently, but I think his questions are pertinent to, the chronic care professional certification. So Joe asked, any clinical pearls or success stories from motivating those who don't want to exercise or have given up on life, so to speak?
Yeah. Oh, that's a great question. And I think if you meet somebody that you've perceived they've given up on life, it means that somehow they've been beaten down by what other people have been telling them up to that point. So you have the possibility to go ahead and intervene and give them back, find out why are they beaten down by life? What do you think's going on? Why do you think this has happened to you? I mean, literally, I asked that. And then they'll go through, they'll respond, well, I have this disease, and that's just the way it is. I have arthritis. I had a patient once that came in, and I'm doing and this was before I really knew MI. This is a long time ago. And I'm doing the interview and I'm trying to get the history from her. And she had been referred to me for a balance issue. And she goes, well, don't you think that I need to have another MRI so they can see if my brain has come back together? And, the first time I heard it, I just thought I didn't hear it right. And this was before I think I was better at listening. And so I just continued. And then she said it again. And then I was like, okay, I have to understand why she's saying that. And so I asked her, what do you mean by your brain is apart and that you need an MRI? And she goes, well, after I had my stroke, I went to the speech therapist and she told me that my brain was in two different pieces. So the speech therapist was simply trying to tell her she had two halves to her brain, but that is not what this patient heard.
Oh, wow.
So, and I'm seeing her 2 years later. So for 2 years, she's thinking that. And so she's like, well, until my brain comes back together, there's really no hope for me. So that was an easy fix.
Yeah.
But so I think sometimes what you have to do is figure out, why do they think like that? What's happened? And the only way you get that is by asking them, what are you worried about? What's your greatest fear? Why don't you think this can be any better? I mean, but as open-ended as possible. You don't want them to say yes or no. It's got to be some conversation that goes with that.
Yeah. And I'd like your thoughts on this, but when I read Joe's question, I thought of the stories of those patients that do have potential to improve from exercise. But then I also think of those patients to where, sometimes I feel like we need to respect their dignity and respect their feelings about giving up on life, in the sense of I've had a few patients that, are in their mid-90s, have lived an amazing life, and they're the most content people ever, and they're ready to go. And
right.
And I feel like, especially for me coming out of school, I was all about, you need to eat better, you need to lift heavy things, you need to do this, do that, delay death, do everything you can. But then to just have a realistic perspective that, some people it's okay if they don't want to exercise or they want to, go to McDonald's and enjoy that or whatever that they want to do that is not, termed healthy in our eyes. We still need to give them that dignity. What are your thoughts on that?
Oh, I think I'm so glad you brought that up, because that's a very important concept to understand. And this goes back to that it's our patient's choice, and we're giving them the autonomy to make that choice. And yes, I mean, at some point in time, people make the decision that they're tired. Mm-hmm. They've done everything, and they just really have no more energy to put forward towards that. And actually, that kind of energy is taking away their last joy for whatever time frame they have. So no, I don't want to take away that joy. Yeah. But I want to support movement in a way that, so now we're sort of talking about more of the palliative care kind of concept of right. We need to support movement so that, all right, you're not going to have some other skin breakdown issue, or we'll just keep general circulation so your joints can be comfortable, because we don't want any extra pain. And so then you're changing the conversation to meet their needs. You can still get movement, but we've changed the conversation to meet their needs and what their goal is for that time. So yeah, we have to. I mean, it is their choice, and that's a wonderful thing to bring up. That no, we don't take that away from people.
Yeah, and that was a good point you mentioned about the palliative care concept. So Joe asked another question: what are your thoughts or approaches on nutrition with the older adult as it relates to wellness and disease prevention?
Right. So for nutrition, I think it's important that we just have a general conversation about it. So I had one patient, so I don't have a nutrition specialty. I wouldn't mind getting that. That might be one of the next certifications I would do, so that I could add that maybe more specifically into patient care. But I don't have that, so I know when I need to refer out. And I definitely, when I have a patient that I think would really benefit from having some excellent nutrition counseling, I will recommend that. But in general, I mean, we can just talk about the importance of protein, the importance of good fats. I had a home care patient that I walked in, so she was only 45, congestive heart failure. I mean, it was just a really, really difficult situation. So we have a hospital bed in her mobile home. She can no longer prepare her meals. She has extended family living in a small space. I mean, you do home care, so you know how sometimes it's not always the best situation. So, and she was at least 100 pounds overweight. Her blood pressure is not normal. Her resting heart rate's 110. So we have lots of things going on. And sitting on her bedside table is a can of soda, a candy bar, and a few other things. And so just what people were giving her, because if they were gone and she couldn't get out of bed, they were just trying to leave stuff for her. And somebody maybe wasn't in the house all the time. And so I'm not starting with that right away, because this is how it won't go well, is to say that, you shouldn't be drinking that soda and you shouldn't do this. And so when I see a patient like that, those individuals know, she knows she's 100 pounds overweight. She knows that her health is really, really in a difficult place right now. We really don't need to say that again. And I didn't say any of that first time. We just talked about how we'd work on getting up and, what were the goals? What would you like to start with? Start that. The next time I come in, and maybe I must have done some sort of conversation about just try to drink a little more water. So I'm talking about what I want her to drink instead of what I don't want her to drink. Try to drink a little bit more water. And then the next time I come see her, her first comment to me is, she goes, no one's ever talked to me like you have before. They always made me feel bad first. She goes, so I'd like to have a little bit more information about how to eat better. I didn't even have to start the conversation.
Yeah.
So it's just trying to figure out, as soon as you feel like the MI term is discord, there's starting to be a little bit of a roadblock, people are starting to say, well, no, I can't do that. Okay, well, that means for you to change your tone and for you to change your way. That's your clue. It's not about the patient being a problem. It's about you. Yeah. So as soon as we can get that, it'll be helpful.
Yeah, you are your own worst enemy. And honestly, I think I mentioned this in that Matt Miller podcast, is these communication principles, I mean, my gosh, they are not limited to patient interactions. I mean, that's good in marital counseling. That's a good way to be a good friend or a family member. So that's what I love about, I mean, it seems like common sense, but in reality, we don't practice these things. But I mean, they will impact so many areas of our lives in terms of communication. So I'm excited to check this out. I'll put the link to the certification in the show notes for sure. And then also the article from, was it Black?
Yes, Beth Black. That's a great case report. And I think there's some really good information. It's an easy read and really shows why promoting MI would be very helpful for all of us.
Yeah. Okay. So let's wrap things up. I'm going to ask one question, and I've already asked you my favorite question, the geriatric rehab one. So we're going to ask a different one. So let's say you have every DPT student in a room in front of you, and what would you want them to know in regards to, what we've just talked about for the past, 30, 40 minutes or so? What's one thing that you would want to stick on their mind?
Well, I say this to my students a lot because the courses that I tend to teach are the soft skill courses, so the communication, the professionalism type courses, and then basic skills, which are really easy to hone in the need for communication. So if I had them all, and these were people I didn't know, I would say that your technical skill, yes, will take you far. So like if you're really good at a particular technique, if it's a neuro technique or an orthopedic technique, your evaluation skills, they'll take you so far. But your communication skills are what are going to allow you to become a master in the profession. So if you can try to remember that, even though we keep throwing techniques at you all the time, it is really, when I think back of the greatest physical therapists I ever observed, the commonality was not the technique. The commonality was how they spoke to their patients. So that would be the thing. If you want to be a master in the profession, yes, of course, we have to be skilled with our hands. But one of the greater skills, it becomes the words that come out of our mouth.
Preach it. Preach it. I know two people are pumping their fists as we speak, Jerry Durham and David Reed. I mean, that's their soapbox right there. So I really appreciate you just saying this on this podcast, but then, day in, day out, saying these things to your students. I know if they're not grateful right now in your class, they're going to be grateful, at least in a few years out of school when they have that very difficult patient interaction and they think, what would Kathy Shirley do right now? So let's give the listeners an opportunity to, ask questions or interact. What's the best way to interact? Which I know you now have a Twitter account.
Yeah, so I'm starting I'm starting to really look at it. How much I can interact on that? That's probably not the best. I mean, I will look at it, but not on a daily basis. Okay. I look at my email almost every 2 hours because of the things that I have to keep up with. Yeah. So that is like the easiest way to get me. But I will look at both. So email or Twitter. I'm getting there. I promise I'm getting there.
Okay. Twitter is KShirley983_D. I know you're in the Senior Rehab Project Facebook group, so people can go to seniorrehabproject.com and sign up and get access to that. And then I'll put a link to your email in the show notes if that is allowed.
Yes, that's great.
Okay. So once again, Kathy Shirley, I appreciate your time. I love interacting with you. Just love what you're doing, your enthusiasm. And yeah, you're a hope dealer. You're just spreading good messages to the students and, in the interactions on social media. So it is greatly appreciated. And I hope to actually meet you in person sometime.
Yeah,
at
we'll see. Are you going to go to CSM? So we'll make sure. I am. Make sure to maybe. All right. So I'll see you at CSM for sure.
All right. Thanks, Kathy.
Okay, great.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you enjoyed this episode, you should hop on over to seniorrehabproject.com, where you can find more helpful content and how you can join me and many others in the movement that's changing the face of geriatric rehab. I appreciate you, and I'll talk with you next week. But in the meantime, do not forget to stay funky.